Hello everyone and welcome to our presentation. I am Genesis Del Nogal, internal medicine resident from Texas Tech University Health Science Center at the Permian Basin. Today I'm going to talk about an interesting case titled A Good Catch, Purple Globe Syndrome. Hope you enjoy it. This is a 61-year-old female with a past medical history of hypertension and coronary artery disease who was brought to the hospital with altered mental status due to a status epilepticus. She denied any history of seizures, recent trauma, loss of consciousness, headache, dizziness, nausea, or vomiting. The patient denied any history of seizures, neither no previous surgical history, and her family history was non-contributory. She also denied tobacco, alcohol, or illicit drug use. The patient was taking atorvastatin 40 mg daily and metoprolol 50 mg daily. Review of system otherwise was unremarkable. Vital signs were normal except for the blood pressure. On physical exam, she was somnolent and confused, but able to follow simple commands without focal neurological deficits. There were no significant findings on the physical exam except for their neurologic status described before. Laboratory studies and admission were significant for leukocytosis, and the complete metabolic panel showed borderline hypokalemia. Urinalysis and urine drug screen were negative. CT scan of the head showed diffuse parenchymal volume loss, as we can evidence in Figure 1. Here, an MRI of the brain in this slide did not show any acute infarct or hemorrhage, only moderate chronic microvascular ischemic changes. At the emergency department, the patient received multiple doses of lorazepam and was started on levetiracetam, commonly known as Keppra, 1.5 grams twice daily. However, the seizures were poorly controlled despite the treatment, and valproate was started 500 mg every 8 hours, and we consulted neurology. During her hospital course, an electroencephalogram showed epileptiform discharges, and a lumbar puncture was negative for infection. The patient still developed generalized tonic-clonic seizures, and the neurologist decided to increase the dose of Keppra to 2 grams twice daily, and he added phenytoin 100 mg IV every 8 hours. After 2 doses of phenytoin, we noticed a bluish discoloration and swelling on bilateral upper distal extremities noticed in Figure 3. Due to high suspicion of purple globe syndrome, IV phenytoin was discontinued immediately and switched to lacosamide. Purple globe syndrome was managed with upper limbs elevation accompanied by heat and cold application. In this image, we show partial resolution of the swelling and skin discoloration after 2 days of stopping phenytoin. The patient's skin discoloration and edema gradually improved after 1 week, confirming a case of mild PGS. Furthermore, seizures subsided and we were able to titrate anti-seizure medications without recurrence of seizures. In summary, purple globe syndrome is a rare severe adverse drug reaction, typically associated with intravenous phenytoin administration. Symptoms of PGS include dark purple bluish discoloration around the site of IV phenytoin infusion, peripheral edema, and pain. Also, on rare occasions, PGS may progress to compartment syndrome, necrosis, ischemia, or vascular compression. The true pathophysiology of purple globe syndrome is not fully understood. However, it is believed to be due to a chemical irritation secondary to high alkalinity of phenytoin and propylene glycol. The alkaline solution could stimulate vasoconstriction and thrombosis, producing extravasation into the surrounding interstitium. According to the data from 2 institutions, the incidence of PGS after IV phenytoin is between 1.7 to 5.9%. For risk factors, those aged 60 years and older, female sex, sepsis, history of chronic debilitating disease, and those who receive larger and more frequent doses of IV phenytoin are at an increased risk for this syndrome. Several published case reports noted improvement of mild cases of PGS with supportive measures, such as discontinuing IV phenytoin, limb elevation, heat or cold application, as in our case, and resolution varied from days to weeks. On the other hand, severe cases may require emergency surgical intervention, like fasciotomy, to relieve pressure and restore blood flow. In conclusion, doctors should be aware of this uncommon adverse reaction of IV phenytoin and should discontinue the drug promptly if the syndrome is suspected to avoid further complications. We recommend using an alternative anti-seizure medication in patients with increased risk for PGS. Importantly, effective teamwork between multidisciplinary team members, including neurologists and hospitalists, is crucial to achieving prompt diagnosis and optimal recovery. These are the references that were used. Thank you for listening, and it has been an honor to be here.